I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Without heart, lymphoma occurred in approximately 10% of persons living with HIV. Lymphoma in AIDS is often extranodal and involves preferably brain and abdomen. Hodgkin's lymphoma, although not an AIDS-defining disease, is also more frequent in persons living with HIV. AIDS patients with lymphoma usually have advanced immune deficiency with CD4 counts below 50, particularly those with primary brain lymphoma. Hodgkin's lymphoma is an exception in that it commonly occurs at CD4 counts above 200. Standard incidence ratios compare a population of interest with the general population. In the following slides, the population of interest are the persons included in the Swiss HIV cohort study, and the control population is the age-adjusted Swiss population. In these and the following graphs, the y-axis shows the standard incidence ratio SIR, and the x-axis categories of CD4 counts. For Kaposi's sarcoma, the overall SIR is about 200, varying from 50 in those with CD4 counts above 500 to more than 500 in those with CD4 counts below 100. For non-Hodgkin's lymphoma, the overall SIR is around 80, varying according to the CD4 count from 35 to 150. For Hodgkin's lymphoma, the overall SIR is about 20, varying from 10 to 30. What is the influence of highly active antiretroviral therapy on these standard incidence ratio? Well, for KS, the SIR dropped from 192 to 19, or 90%. For non-Hodgkin's lymphoma, from 76 to 19, or 75%. In contrast, the incidence of Hodgkin's lymphoma did not decrease at all. Histologically, the frequent types of lymphoma are the Burkitt type lymphoma, with its characteristic white patches on a blue background, the quote-unquote starry sky appearance, the diffuse large B-cell lymphoma, and Hodgkin's lymphoma. Note the pathognomic Reed-Sternberg cell. A short chapter on lymphomagenesis in HIV with a particular focus on Burkitt's lymphoma. BL is a consequence of a chromosomal transposition, most often involving chromosomes 8 and 14, here depicted schematically with their short arms, centromeres, and long arms. At the end of the long arm of chromosome 8, there is a sequence containing a gene called c-MYC. At the end of the long arm of chromosome 14, there is a region coding for the variable region of the heavy chain of immunoglobulin, VH, followed by a region of no interest in this context, which we'll call Y. What is and what does c-MYC? The avian leukosis virus, AVL, causes avian myelocytosis, a disease associating leukemia with many other tumors. Myelocytosis is due to the MYC oncogene carried by AVL. When a homologue of the MYC gene was discovered in mammalian cells, the viral gene was renamed vMYC and the mammalian gene cMYC. cMYC produces a transcription factor which activates many other genes, some of them causing cancer. The chromosomal change which causes Burkitt's lymphoma is a balanced transposition. Here we see again chromosome 8 with the yellow part containing cMYC. During transposition, the sequences containing cMYC insert distal to VH on chromosome 14, whereas the Y sequence, which was originally on chromosome 14, attaches to the remaining stump of chromosome 8. Because the yellow sequences containing cMYC are bigger than the orange sequence Y, the transposed chromosome 14 becomes longer than its non-transposed mate, whereas the transposed chromosome 8 becomes shorter. The piece containing cMYC is shorter than the Y piece. Therefore, transposition shortens chromosome 8 but lengthens chromosome 14, as shown in the karyotype at right. MYC, EBV, and HIV each have complementary roles in lymphomagenesis. After the transposition, cMYC is activated by the promoters governing the immunoglobulin gene loci, VH. This causes cell growth and proliferation, but also induces apoptosis and senescence. For lymphomagenesis, EBV gene products inhibit apoptosis, and HIV reduces immune surveillance of neoplastic cells, among other postulated mechanisms. Let us now turn to the study of some cases. As you can deduce from the low resolution, this CT scan dates from the 1980s. The patient, a 34-year-old gay man, presented with weight loss, abdominal discomfort, and lymphopenia with a CD4 count of only 28. An enormous abdominal mass was palpated, which turned out to be a lymphoma. Malignant lymphocytes predominate with large nuclei and little cytoplasm. They appear blue, interspersed with macrophages with more cytoplasm. This aspect has been compared to a starry sky. Immunoperoxidase staining for CD20. The CD20 molecule is present on all lymphocytes of B lineage and is the target of several therapeutic monoclonal antibodies, for instance rituximab, MabThera. Slides were stained with antibodies against kappa light chains, left, positive, and lambda chains, right, negative. Such a result implies monoclonality. Burkitt-like lymphoma can occur in HIV-infected children. Note malnutrition and the protuberant abdomen in this child from Thailand. The abdominal cavity is filled by an enormously enlarged liver. The spleen is also enlarged. In this low-power view of fragments of the liver biopsy, the portal spaces are infiltrated. A higher power view of the liver biopsy reveals large lymphoblastic cells with prominent nucleoli and basophilic cytoplasm. Back to adult patients. Here we have prominent retroperitoneal lymph nodes due to a large B-cell lymphoma. Lymphomas can be very aggressive. This patient had a CD4 count of 148, fever, and weight loss. A partly calcified mass superior to the right kidney, was discovered on September 15th. He also had a remarkably high EBV viremia of 7 million. Needle biopsy yielded malignant lymphoblasts, which were CD20 positive. Note the increase in size in barely 2 months. Another example of an aggressive large B-cell lymphoma, which relapsed after an autologous bone marrow transplant and involved the thoracic wall and left axilla. The next patient is a 70-year-old girl with congenitally acquired HIV infection. What we see here is the infiltration of the posterior wall of the rectum due to a diffuse large B-cell lymphoma. A remission was obtained by treatment with monoclonal anti-CD20 antibody rituximab. The patient refused treatment with cytostatic drugs and was lost to follow-up. 6 months later, she relapsed with a mixed retroperitoneal abdominal mass infiltrating the duodenum. Distension of intrahepatic bile ducts is shown on the right. Treatment with high-dose steroid was followed by intestinal perforation and sepsis. Unfortunately, she did not survive. On to brain lymphoma, where we'll start with a mystery. A young homosexual male teacher who had lived in San Francisco from 1978 to 1980 with a history of several sexually transmitted infections presented with pancytopenia, candidiasis, right hemiplegia and aphasia and died shortly thereafter. CT showed an ill-defined infiltrating mass in the left hemisphere, and at autopsy this mass was shown to be a Burkitt-type lymphoma. This happened in early 1982, before HIV testing was available and before the relation of lymphoma to HIV was discovered. To our great amazement, his stored serum tested negative for HIV in 1990. This case defies easy explanation. Is it a reminder that brain lymphoma occurs in HIV-negative persons, albeit rarely? Or, more trivially, that 2 tubes were mixed up? The T-weighted MRI shows a heterogeneous lesion in the left caudate nucleus and internal capsule. This lesion enhances with gadolinium on this T1-weighted image. There is a moderate edema, see the surrounding hyperintensity, and mass effect. Another image of primary brain lymphoma in an AIDS patient. This and the following images are from one of the earliest AIDS patients in Geneva. This was a middle-aged man who had lived in Mozambique. He presented in the fall of 1982 with unexplained thrombocytopenia, which responded to high-dose prednisone. However, in early 1983, he lost weight, had fever, and was more and more lethargic. A lumbar puncture revealed malignant-looking cells in his spinal fluid with large nuclei and nucleoli, basophilic cytoplasm, and mitotic figures. A brain biopsy showed perivascular infiltration by malignant lymphocytes, which is typical for AIDS-associated lymphoma. He also had evidence for CMV encephalitis, not shown here. Remember, this was in early 1983. We sent his serum to Françoise Barré-Sinoussi, who performed an immunoprecipitation test with what was then called LAV, later renamed HIV. The test was positive. With highly active antiretroviral therapy, cerebral lymphomas have become rare, but here's a man who is known HIV positive since 2012 and treated with Genvoya. On July 17, 2022, he had a seizure in France. The CT scan was reportedly within normal limits. On August 31, 2022, he had a second seizure while residing in China and returned home to Geneva. The CT scan and MRI showed several distinct lesions, the largest of which is depicted here. His HIV viremia was undetectable and he had 675 CD4 cells per microliter. The infectious disease serologies were all negative, including toxoplasmosis. In the cerebrospinal fluid, there were 18 cells per microliter, 92% lymphocytes, and 1 gram per liter of proteins. The PCRs for toxoplasmosis, tuberculosis, cryptococcosis, and EBV were all negative. The brain biopsy revealed a large cell lymphoma of B-type, high grade. This is a reminder that standard incidence ratios for lymphoma remain clearly above 5 in people living with HIV, even when well controlled by heart. The differential diagnosis is more fully treated in the video about Toxoplasma encephalitis, which is part of this series on opportunistic disease in HIV infection. All brain masses, including glioblastoma, metastases, and abscesses, must be considered. In the context of HIV, Toxoplasma abscess, particularly in IV drug users, bacterial abscess, particularly in patients from developing countries, tuberculomas and tuberculous abscesses, and particularly in patients from South America, Chagas disease. Here is a case to illustrate the difficulties of differential diagnosis between lymphoma and Toxoplasma encephalitis. This patient presented with recurrent symptoms after recovery from cerebral toxoplasmosis. Note the residual calcification. In addition, note the contrast accumulation in periventricular regions compatible with CMV infection or lymphoma. At autopsy, lymphoma was found. Although irregular uptake of contrast and the presence of only one versus several lesions is in favor of lymphoma, the two conditions often cannot be distinguished radiologically. This is an HIV-positive patient with malignant lymphoma, large cell, B-type, hepatic, and retroperitoneal in 2002, treated with monoclonal anti-CD20 antibodies and chemotherapy. In May of 2004, she presented with headaches and confusion. The PCR in the cerebrospinal fluid was positive for Epstein-Barr, but negative for toxoplasmosis. Treatment with irradiation and methotrexate was partly successful, but the patient died in May of 2005. New lesions were evident in the cerebellum before her demise. To finish, let's look at some special cases: Hodgkin's lymphoma, Castleman's disease, and primary effusion lymphoma. Hodgkin's lymphoma in HIV/AIDS is not an AIDS-defining disease. Contrary to other lymphomas, its incidence among HIV-infected persons has not decreased after HAART. It is now among the most frequent HIV-associated lymphomas. It may occur with high CD4 counts, although it is preceded by lymphopenia in patients on highly active antiretroviral therapy. This 54-year-old man with long-standing treated HIV infection and a CD4 count of almost 600 developed a painless enlargement of a cervical lymph node. The histology showed Hodgkin's disease. These images are from a PET CT scan where metabolically active tissues such as tumors light up. Between the two scans on October 2nd and December 4th, the patient had received 4 cycles of ABVD chemotherapy. Multicentric Castleman's disease with fluctuating fever, lymph node swellings, and characteristic onion skin histology is not considered malignant. However, in the HIV population, the incidence of lymphoma is high. In a group of 70 patients with CD, after a median follow-up of 2 years, 24 developed lymphoma. Most of them were on effective heart, and 18 of these 24 also had Kaposi sarcoma. The insert shows a Kaplan-Meier curve established by Eric Oxenhandler and shows that after about 8 years, 50% of patients with CD had developed lymphoma. Here is a case of brain lymphoma 23 months after multicentric Castleman's disease. The tumor contained large HAV8 positive cells, while staining for EBV was negative. The last patient was 34 years old with HIV, hepatitis C and hepatitis B infection, treated intermittently with efavirenz and combivir. When he presented with fever, weight loss and cutaneous Kaposi sarcoma, he had a CD4 count of 457, 19%, and a viral load of 5,000. The lymph node biopsy showed Castleman's disease and Kaposi sarcoma. On the left, an abdominal CT showing a large liver and even more massive spleen. On the right, an atrophic follicle containing radiating blood vessels simulating a lollipop appearance, and surrounding mantle lymphocytes forming a ring imparting an onion skin appearance. He was treated with liposomal doxorubicin and went into remission. In October 2006, however, he had renewed fever and new precordial pain. Note the increase in the size and the tent-like appearance of the heart in October 2006. A frame from a two-dimensional echocardiogram showing the pericardial effusion, that is the echo-free space shown with the arrows. The pericardial effusion contained large cells with a basophilic cytoplasm and prominent nucleoli. These cells stained negative for CD20 but positive for CD38, as is suggestive of primary effusion lymphoma. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.